Thank you.
You're welcome.
Dr. Shafer, looking at the findings of the 2002 article, again, that specifically had addressed the 1988 Simons article, can you explain what is shown in this total propofol dose in milligrams column and the amount of excreted unchanged propofol column?
Yes. Would you mind moving it to the right so I can just explain the first column?
Yes.
Okay, good. So this is a study that was done in 5 patients undergoing major surgery. And these 5 patients received continuous infusions of propofol during the surgery. This shows how long the surgery went for. So this person, for example, 160 minutes, 120 minutes, and so on. TCI is how the propofol was given. It stands for target controlled infusion. But the main thing to know is it's the duration of the propofol infusion itself. And you can see that the infusion ran longer than the surgery, which is what you expect. This looks at the total amount of propofol in milligrams that was delivered in each patient. And you can see they're sizable doses, typically running, well, let's see, from a low of about 1,300 milligrams to a high of 3,300 milligrams. The average amount of propofol winds up being 2,000 milligrams. Now that's the volume of the urine, but the thing I want to focus on here is the amount of excreted, unchanged propofol, because that's really the question on the table. Michael Jackson's unchanged propofol in the urine, what does that tell us about the amount of propofol that he received? What you can see here is that the average was 70.71 micrograms of unchanged propofol, which is quite close to what was measured in Michael Jackson, 82.5 micrograms. 70.71 versus 82.5. Very similar. And you can see that that was associated with a dose of 2,000 milligrams.
Dr. Shafer, based on this 2002 article, which you characterize as the definitive article on this subject, in your opinion, does this absolutely rule out the hypothesis put forward by Dr. White?
Absolutely.
And is it consistent with the hypothesis put forward by yourself?
Well, it actually suggests that Michael Jackson received more propofol than suggested by my simulations.
But this is, to be fair, a mean or an average amount?
Correct.
Okay.
Correct.
Now, on the standard of care, Dr. Shafer, would you agree that any requisite standard of care, either for a hospital setting or an office-based setting, that the need for even for monitoring and safety precautions would be even greater in a home setting?
Yes.
And could you explain that, please?
Yes. Anesthesiologists spend a certain amount of time providing care in what we call remote locations. And a remote location might be a radiology suite, where we're not often present, or perhaps a difficult patient in an eye clinic, or a difficult patient in some location where we're normally not giving anesthesia. And what we're taught, and what I now teach, is that when you are in a remote location, you have less tolerance for error. You have to be particularly careful. You have to adhere to the standards as carefully as possible, and the reason is you have no backup. You're by yourself. So in a remote location, the teaching, understandably, is that you take no shortcuts. So to your question, if there were such a thing as bedroom-based anesthesia, the standards would be, the standard guidelines would be considered a minimum, because there's no backup. There's no tolerance for error. If you have an error, you'll have a mortality.
Thank you, Dr. Shafer. Nothing further, Your Honor.
Thank you. Cross-examination. Mr. Flanagan?
Thank you.
You're welcome.
Could I have people's 207? Dr. Shafer, in the report that you wrote in this case, isn't it a fact that you indicated that 5 milliliters of lidocaine injected between the hours of 10 and 12 would correspond with the autopsy levels of lidocaine found in the femoral vein?
I'd have to look at the report again. If you have a copy, I'll be happy to look at it.
Please.
So can you, now that I have the report in front of me, can you repeat your question, please?
Didn't you indicate in the report that you wrote that 5 milliliters of lidocaine injected between the hours of 10 and 12 would correspond with the lidocaine levels found in the femoral blood at autopsy?
No, that's not what the report says.
What does your report say?
The report suggests initially a mixing of 10 of lidocaine, 10 milliliters of lidocaine with 100 milliliters of propofol, and performs a simulation. I then and the simulation does not give us a high level, and then I suggest that the 10-to-1 ratio was probably wrong, and what the report, if I may actually read from my report, the most likely explanation is that Murray did not use the more or less standard dilutions, this being standard for an anesthesiologist, but rather diluted lidocaine with propofol 1-to-1, i.e., meaning as an example, mixed 5 mils of lidocaine with 5 mils of propofol. But I'm just showing that it's the ratio. I'm not saying that that's what the simulation was. That's just to explain what 1-to-1 means.
And Dr. Shafer, you could probably sit back a little bit.
Oh,
rather
sorry.
Than, that's okay.
Yes. So that you've misread my report.
Doesn't that sentence, that last sentence actually say that diluted lidocaine with propofol 1-to-1, i.e., mixed 5 milliliters of lidocaine with 5 milliliters of propofol, that would have produced about exactly what the lidocaine concentration measured in femoral blood at autopsy? Is that what, if you complete that whole sentence, is that what it says?
But we're talking about the larger dose. We're not just talking about 5 mils of lidocaine.
Would you read the entire last sentence of that report, starting with
The.
the?
Okay.
And sit back just a tad.
Sorry, yes.
Thank you.
Right. The most likely explanation is that Murray did not use the more or less standard dilution, but rather diluted lidocaine with propofol 1-to-1, i.e., mixed 5 mils of lidocaine with 5 mils of propofol. That would have produced almost exactly the lidocaine concentration measured in the femoral blood at autopsy.
Thank you. Now, you have rejected the Simons article, is that correct?
No, the Simons article is fine. It just has to be properly interpreted. I've rejected your interpretation.
Okay, and that's really what DeWitovitz said, isn't it?
Yes, I've discussed it actually with the principal investigator, Malcolm Rowland, and it's what he said also.
Okay. In the DeWitovitz article, how do I unfreeze? Good.
Okay, you're just press free, so you're good.
For the benefit of the reporter and the jurors, you've made reference to an author, Mr. Flanagan, with a W?
Yes,
I didn't catch it.
This is exhibit number 247, the investigation of propofol renal elimination by HPLC using supported liquid membrane procedure for sample preparation by, how do you say that name?
Well, it looks to me like it's derived from David, so I would say DeWittowitz.
Okay, now in this DeWittowitz article, I wonder, doesn't it state in this highlighted portion here, according to Simons et al., only less than 0.3% of the applied propofol dose is excreted into urine in an unchanged form. Their papers are cited by many authors studying the metabolism and elimination of propofol. And then it goes on to distinguish the Simons article by saying, but it should be stressed that the mentioned value was estimated using subanesthetic doses of radio-labeled propofol in healthy volunteers. The aim of the present work is to investigate the amount of propofol excreted into urine in an unchanged form during anesthesia and for the first 48 hours after anesthesia termination. It made a distinction between anesthesia levels and subanesthesia levels, didn't it?
If you're able to.
I'm not sure what your point is. They're simply describing one level as subanesthetic because it was 0.5 milligrams, 0.47 milligrams per kilogram. And in this article, the propofol is being used for anesthesia. That is correct.
In this case, 25 milligrams per, when you reduce it to the same terms, was a 0.4 milligram per kilogram induction, wasn't it?
25. I don't follow your math.
This assumed that Michael Jackson weighed 61.7 kilograms.
Okay.
He was given 25 milligrams. That is 0.4 milligrams per kilogram, isn't it?
I don't have a calculator with me. If you'd like to calculate it.
Well, it's ballpark.
If you'll assert it, that's fine.
Okay. And when it leads to a level of 1 microgram per milliliter, that's subanesthetic, isn't it? Overall.
In a patient with no other medication on board, perhaps. In a patient with medication on board, hard to make that determination.
Okay. Now, neither one of these articles, Simon or DeWittowitz, was talking about medication, other medication, were they?
In the DeWittowitz paper, if you go back, I believe they received a pre-medicant, but I'm not certain. We'd have to look at the paper.
If I read it, I probably wouldn't understand it anyway. But you will give me the fact that the dosage of 25 milligrams per kilogram is a subanesthetic dose, isn't it?
25 milligrams per kilogram would be an enormous dose.
I mean, 25 milligrams in 61.7 kilograms is a subanesthetic dose.
In most patients, that would be a subanesthetic dose.
Okay. And the Simons article deals with subanesthetic dose. The DeWittowitz deals with anesthetic doses, doesn't it?
The DeWittowitz article definitely deals with doses that are larger, actually by 55 times. They calculate that for us.
Thank you. Nothing further.
Flanagan, thank you. Redirect examination, Mr. Waldron.
Thank you.
Thank you.
Dr. Shafer, are the findings from the DeWittowitz article from 2002 in any way dependent on the dose, or is it actually giving a measurement of how much unchanged propofol you'd find in the urine?
What DeWittowitz actually notes in his discussion is that the use of larger doses increases the accuracy of the results. It has no bearing on the 0.004% at all, other than to increase the certainty about that estimate.
Thank you, Dr. Shafer.